The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hello everyone, my name is Dr. Carl Avilio, but please feel free to call me Dr. Carl, and welcome to the Top-Notch Internal Medicine lecture on GI, Rheuma, Allergy, and Immunology. So I specifically chose the topics included here based on feedback from the March 2023 PLE because, as you know, the trends in the PLE are always evolving and always changing. And so we try our best to make sure that what came out in the recent PLE is included and discussed in the lecture, so you'll have the best chance to pass the exam. So the way we're going to do the lecture is we're going to go through some questions with answers before we dive into the lecture discussion. This will serve as a form of active recall to help you remember more information more quickly. And some questions, as you will see, are cascading questions, where getting the correct answer to the next question depends on whether you got the first one correctly. But this pattern of questioning has decreased in frequency in the previous PLEs. Okay, but this was very popular maybe 2 years ago. However, this doesn't mean that we should neglect these cascading questions, even if they have already decreased in frequency, because we really can't predict what type of questions will come out on your exam. So it's better to be prepared. As they say, hope for the best, but always prepare for the worst. That's why in the slides here, we will still discuss cascading questions. Okay. So we start with gastroenterology first, and with the topic of GERD. Okay, so a 25-year-old female comes to, so here's one of the first cascading question. So a 25-year-old female comes to the emergency room complaining of substernal chest pain characterized by burning sensation associated with unpleasant taste, sore throat, and cough. What is the most likely diagnosis? So very obviously, ang topic natin is GERD. So the most likely diagnosis is GERD. So but that shouldn't be the way na i-analyze nyo yung mga questions sa PLE. So we'll go through the questions then, okay? So firstly, 25-year-old female siya. So ano ba yung mga differentials mo pag ang question stem nakasulat ay chest pain? So firstly, you should first think of life-threatening na mga diagnoses. Okay? So you have apat na diagnoses ang kailangan mong i-rule out sa chest, sa heart, 2 diagnoses kailangan mong i-rule out sa lungs, and then 2 diagnosis din ang kailangan mong i-rule out sa esophagus. Okay? So yun yung mga life-threatening disorders na kailangan mo muna i-rule out before you go into the other na mga diagnoses that also present with chest pain. Okay? So yung 4 na diagnoses na life-threatening that pertains to the heart are ACS, acute coronary syndrome, aortic dissection, Takotsubo, cardiomyopathy, and cardiac tamponade. 4. Okay? But these are not, you won't find this in Harrison's. I'm just giving you like a mnemonic to help you think through it quickly. Okay, and then we also have two diagnoses under ng pulmonary na life-threatening. We have pulmonary embolism and pneumothorax, and under esophagus is esophageal impaction and esophageal perforation. Okay? So 25-year-old female, it's less likely na ang 25-year-old female is meron ng ACS kasi ang ACS nagpe-present siya sa mga patients na usually is ang ages mga 50 to 60 and meron silang comorbidities such as diabetes or hypertension. Yung mga may aortic dissection naman, they would, and the character of the chest pain ng mga patients na may ACS is heaviness, chest heaviness. Tapos it's also associated with symptoms na parang sense of impending doom. Okay? You will read that sa Harrison's. And it's also precipitated by activity and relieved by rest. No? That's for stable angina. Pero as you again, nasa topic pa rin tayo ng ACS na precipitated by activity and relieved by rest pag stable angina, and then as the condition worsens, yung rest hindi na siya nakakapagpa-relieve ng chest pain. So ang tawag na sa kanya is unstable angina. Up until such time na even during rest, magkakaroon pa rin siya ng chest pain. So that's the time na magkakaroon na siya ng pwedeng STEMI or non-STEMI. Okay? So in this patient profile, 25-year-old female, it's less likely na ACS to. Okay? Kasi ang character ng pain nitong 25-year-old female na ito, burning sensation associated with unpleasant taste, sore throat, and cough. Okay? So it's less likely ACS. How about aortic dissection? Ang character ng aortic dissection is tearing chest pain radiating to the back. Okay? And dapat most of the time it's associated with hypertension, aortic dissection. And yung age ng mga patients sa aortic dissection is not a 25-year-old female. Okay? So how about Takotsubo cardiomyopathy? It usually presents with after a severe emotion. It's actually a severe emotional reaction. Parang kasi pag nagkaroon ng severe emotional event yung person, nagre-release yung body ng excessive amounts of catecholamines that eventually lead to the signs and symptoms of Takotsubo cardiomyopathy. Kaya how about cardiac tamponade? It should have ang cardiac tamponade associated siya with yung Beck's triad, as we know, ng hypotension, muffled heart sounds, and distended neck veins. No? How about pneumothorax? Kunwari, spontaneous pneumothorax, walang sinabi na siya ay may smoking, and hindi siya pleuritic chest pain, no? Kasi that's the kind of chest pain associated with pneumothorax. Yung when the patient inhales deeply, that's the time na magkakaroon ng chest pain. Yun ang pleuritic chest pain. Pero hindi na sinabi dito. Sabi dito is associated with unpleasant taste, sore throat, and cough. How about pulmonary embolism? Well, dapat sana meron siyang parang mga risk factors for having DVT which would lead to pulmonary embolism, such as hypercoagulable state, maybe cancer, or after an orthopedic surgery, okay? So, or after long hours of travel, so wala siya no? Well, at least hindi na mention. And then esophageal impaction it happens kung may pill esophagitis, nag-take ng malalaking pills like for example yung mga bisphosphonates, no? Yun, pwede magka-pill esophagitis doon or magbumaran, magkaroon esophageal perforation, pero hindi yun sinabi dito, no? Anyway, so the fact na rule out mo na yung signs, yung mga na yun, yung mga life-threatening diseases na yun, it narrows down yung set of options na you can be more sure na yun ang sagot, no? So in this case, in a 25-year-old female na may substernal chest pain, burning sensation of substernal chest pain is more likely associated with a diagnosis of GERD, no? Tapos may unpleasant taste pa siya in sore throat. So tulad ko, kaya ako nagbaburp kasi meron akong GERD. Okay. Anyway, okay. So that is GERD. So what is the next best step? Okay. So the next best step is start PPI. Okay. So bakit wala tayong ginawang ibang tests? Actually, kasi sinabi sa Harrison's, after excluding alarm factors, patients with typical GERD do not need further evaluation and are treated empirically. Okay? So, kunwari, tulad ng ginawa natin, ni-rule out muna natin yung mga life-threatening disorders of ACS, aortic dissection, pulmonary embolism, and pneumothorax, and esophageal impaction, and esophageal perforation. Pagka-rule out natin nun, and na-recognize mo yung constellation of symptoms that point to GERD as a most likely diagnosis, you do not need any further tests. Okay? Wala kang kailangan gawin na iba. You should just treat the patient empirically with PPI. Okay? That's why it's the next best step. Okay? So what do you recommend if dysphagia is present? The correct answer is upper endoscopy. Why? Kasi nga sabi ko, after excluding alarm factors, the next best step is to treat the patient empirically with PPI. Okay? But, ano ba yung mga alarm factors na kailangan mo na exclude? So we will see that in the next few slides. Okay? But, dysphagia is one of those alarm factors. And if an alarm factor is present sa patient na may GERD, hindi ka mag-PPI, you will go straight to upper endoscopy. Okay? Okay, so what is the pathophysiology of GERD? There are three dominant mechanisms for it. Itong T lesser ang kanilang parang acronym for the first one, transient LES, lower esophageal sphincter relaxations, TLESR, T lesser. And then the second mechanism is lower esophageal sphincter hypotension, and then the third one is anatomic distortion. But out of these three, the most dominant mechanism is transient LES relaxation, the first one that was mentioned. Okay, that is the most dominant mechanism. Now, ang PLE kasi guys, ano siya excuse me. Ang PLE is more of a recall type based of exam as opposed sa mga exams like the USMLE or other medical exams abroad na two-step questions. Tinatanong mostly sa PLE is mga, and parang hindi na siya nagbago since nag-PLE na ako noong 2017, is mostly is recall type based siya, which means one-step questions, which means sabi one-step question is what is the most dominant mechanism of GERD? Ganon. What is the treatment of choice for ganito? What is the next best step? Ganon. So parang hindi mo na kailangan mag-isip ng kung ano yung diagnosis and then ano yung treatment for it, no? It doesn't work that way. May mga questions na ganon, pero relatively less, no? Okay. So, we also have other risk factors that exacerbate GERD or reflux, which are these: obesity, pregnancy. Obviously, because with obesity and pregnancy, the pressure that's yung obesity and pregnancy, it leads to the buildup of pressure inside the abdomen, and it pushes the diaphragm upwards and the stomach. So the stomach contents. So yung mga stomach contents, they go back papunta sa esophagus, which leads to reflux, no? Delayed gastric emptying, meaning the stomach contents don't readily empty into the duodenum. So mangyayari yung stomach contents magre-reflux pabalik sa esophagus. And then you also have disruption of esophageal peristalsis and then gluttony. Obviously, no? Pag marami kang kinain, magre-reflux siya. So what are the signs and symptoms of GERD? We have heartburn and regurgitation. The typical symptoms of GERD are heartburn and regurgitation. Okay? Highlighter, sorry. Okay. Heartburn and regurgitation. May other symptoms tayo na hindi typical, which are these, no? Chest pain, chronic cough, and asthma. Because some of the acidic reflux can get into the airways or to the larynx, leading to laryngitis, or could get into the lower airways, which can lead to reaction of the airways to the acidic reflux, leading to asthma and bronchospasm and asthma. Okay. Now, what is the most severe? The most severe histologic consequence of GERD is Barrett's metaplasia with the associated risk of esophageal adenocarcinoma. Now, tandaan ninyo, kaya ko ito nilagay dito because some students can be confused with what histologic type of esophageal cancer can be caused by chronic GERD. The correct answer is adenocarcinoma. Tandaan niyo yun, okay? Hindi squamous cell carcinoma, adenocarcinoma. Okay? So, ulit, GERD can lead to Barrett's metaplasia dahil yung normally squamous epithelium ng esophagus is napapalitan ng columnar epithelium. That's Barrett's metaplasia. And yung Barrett's metaplasia na yun can lead to esophageal adenocarcinoma, not squamous cell carcinoma, okay? Adenocarcinoma. And then, so here are the etiologic factors associated with adenocarcinoma of the esophagus. And actually, the esophageal adenocarcinoma is the predominant histologic subtype in the US and Western Europe. Okay? So bakit mahalaga na may US and Western Europe? Well, kasi ang ating mga books is based sa US. So kung ano yung sinabing predominant histologic subtype sa US, it most likely yun din ang sagot na isasagot ninyo pag yun ang tanong, no? Even if we're not in the US, since ang books natin ginagawa sa US, pag tinanong is what is the predominant histologic subtype for cancers of the esophagus, the correct answer is esophageal adenocarcinoma din, okay? Here are the etiologic factors for it. Okay? Barrett's esophagus, male sex, cigarette smoking. Okay? Now, what is the treatment for Barrett's esophagus? The correct answer is endoscopic mucosal ablation therapy. Okay? Previously, it was esophagectomy. Okay, so bakit ko ito ina-emphasize? Kasi dun sa 20th edition ng Harrison's, which is yung blue one, esophagectomy pa yung sagot dun. Yun yung management for Barrett's esophagus. Pero sa 21st edition, which is the red one, yung newest na edition, the answer is endoscopic mucosal ablation. That is the current guidelines that for the management of high-grade dysplasia in Barrett's. Okay? Hindi na esophagectomy. The reason is kasi ang esophagectomy is more morbid kasi syempre ano siya it's a more intensive na operation. Okay. So if the patient has typical GERD, it does, as I said kanina, it does not need further evaluation and is treated empirically with PPI. Kaya yun yung sagot dun sa second question dun sa ating question stem kanina about the 25-year-old female. Now, and then yung third question was, mayroon daw dysphagia yung patient, kunwari, na yung 25-year-old female natin, paano pag nag-present siya with dysphagia? Ano yung next step? The correct answer is to do upper endoscopy. Okay? Why? Because ito yung mga indications for upper endoscopy in cases with atypical symptoms. Ano nga ba yung typical symptoms natin ng GERD? Heartburn and regurgitation. Okay. Tandaan niyo kahit yung simpleng ganyan na tanong, what are the typical symptoms of GERD, heartburn, and regurgitation? Pwede yang itanong. Okay? Kahit ganyan lang, nakala mo hindi siya mahalaga, well, typical symptoms, pwede siyang itanong. Bakit ko nasabi yun? Kasi, I think maybe 2 years ago, tinanong kung ano yung cardinal symptoms of heart failure. Na actually, hindi na siya na-mention dun sa 21st edition ng Harrison's, yung the cardinal symptoms of heart failure. Na-mention siya dun sa blue 20th edition ng Harrison's. Hindi siya na-mention sa 21st, which is the red one. So, kaya mahalaga rin na malaman niyo yung mga ganitong terms, no? Typical symptoms, heartburn, and regurgitation. So, tandaan niyo siya kahit it seems like hindi siya mahalaga, no? So, upper endoscopy is indicated in cases with atypical symptoms, failure to respond to therapy, which is PPI, failure to respond to PPI, alarm factors, we will discuss kung ano yung alarm factors dito sa next slide, which are these. And nasa handouts nyo rin naman yan. And upper endoscopy is also indicated to screen for Barrett's metaplasia if the heartburn has been present for already more than 5 years and especially for those na more than 50 years old. Okay? Now, as I said kanina, no further evaluation is needed. They are only treated empirically. But there are some tests that we can do if surgery is contemplated by the medical team, no? And when surgery is contemplated, for a case of GERD, esophageal manometry should be done. Okay? So, kanina ko pa sinasabi ko ano yung mga alarm symptoms na kailangan nating i-exclude before we even decide na i-treat empirically yung patient with PPI. And yung alarm symptoms na yun are the following: dysphagia, odynophagia, unexplained weight loss, recurrent vomiting, occult or gross gastrointestinal bleeding, jaundice, palpable mass or adenopathy, family history of gastroesophageal malignancy. Okay? So, if any of these are present, just one, kahit isa lang, if any of these are present, you will not treat the patient empirically. You will go straight to doing endoscopy. Kaya nga sabi dito, alarm symptoms requiring endoscopy. Okay? Now, another thing is, upper endoscopy is recommended as the initial test in unexplained dyspepsia if the patient is already more than 60 years old. So, yung patient natin kanina is a 25-year-old female. So, hindi pa tayo pwedeng automatically ipaproceed siya sa upper endoscopy. But if the patient natin kanina is maybe a 65-year-old male na may unexplained dyspepsia, that's the time na magdediretso siya sa upper endoscopy. Okay? Now, tandaan nyo tong age na to na more than 60 years old. Kasi doon sa 20th edition, the blue one ng Harrison's, the previous one, 55 years old yan. Okay? Pero dito sa new one, sa red one, sa 21st edition, it's already 60 years old. Pinataas nila yung age threshold. Okay? So that is why pag may mga students na nagtatanong, Doc, meron po akong handouts na last year pa. Pwede bang yun na lang gamitin ko? Tapos iba na yung hindi ko na i-avail yung new handouts for na present for the October 2023. The usual advice ni Doc Broly is wag gamitin yung previous handouts because ito yung reason. Kasi nagbabago yung numbers, nagbabago yung edition, and as the book editions change, we also make some changes dun sa handouts, no? Kasi dun sa exam itself, pwedeng i-present ng examiner na ano yung age. Pwedeng ang ilagay niya is 45, 50, 55, 60. So pag sinagot mo yung 55, pwede kang mamali, no? Well, hindi ka pwedeng mamali. Mali ka talaga. Kasi nga, tinaas na nila yung age threshold to 60, okay? Okay. So, bakit pwede tayong mag-proceed to giving PPI agad, empirically, if we diagnose a patient with GERD? The reason is, kasi the administration of PPI is both diagnostic and therapeutic, no? And, kunwari, nag-respond yung patient sa pagbigay mo ng PPI, it could be diagnostic na, yes, GERD nga siya. Nag-respond siya sa PPI eh. And at the same time na na-diagnose mo na GERD nga siya, therapeutic na rin siya kasi nawala yung kanyang signs and symptoms. Okay? So, the choice between PPIs and H2RAs, yung mga ranitidine, more efficacious ang PPIs as they found, no? And now, the next question is, aling PPI ang pwedeng gamitin? Omeprazole, lansoprazole. There's no major difference that exists among PPIs. Okay, so kahit ano pwede mong gamitin. Okay, and of course, we should also advise the patient to do some non-pharmacologic na mga measures, like avoidance of refluxogenic foods, like fatty foods, alcohol, coffee, possibly coffee and tea, and avoidance of acidic foods, citrus foods, and tomato-based foods, no? Ako kahit na ako ay merong GERD, nagtitreat ako ng PPI, is nagko-coffee pa rin ako kasi kailangan ko yung coffee. So, mali siyang advice. Anyway, okay. Parang naulit lang to. I'm sorry for that. Naulit lang siya. So, for how long? Indefinite yung treatment as necessary for symptom control. And if it's a chronic GERD, we can also go to laparoscopic Nissen fundoplication. Okay, let's go to recalls. So, the following cannot be given in patients with uncontrolled GERD with peptic strictures except, okay, bakit ganito yung phrasing ng aking question stem? Ganito kasi yan. Umuuso kasi sa PLE for the past 2 years yung double negatives sa question stem. Hindi ko rin alam. It's not the ideal way of creating question stems. It's not, kahit mag-search kayo sa Google, this is not the right way. But, ganito mag-ask sa PLE. So, let's just pabayaan na lang natin sila. Okay, so this is a question stem na to. The way na pwede nyong ang technique na pwede nyong gawin is dahil double negative siya, merong not, yun yung tinatawag na double negative question stem, which means cannot except. Kasi may dalawang negatives dun sa question stem, double negatives. So the way na pwede nyong gawin yan, because they are double negatives, they cancel each other out. Which means you can just X it, no? I-X nyo lang as if they were never present doon sa question stem. Tapos basahin nyo na lang. So, kung ganito na may double negatives, tapos kinross out nyo sila, is the way I would read this question stem this time around is the following: which bisphosphonate is given to patients, can be given to patients with uncontrolled GERD with peptic strictures. Ulitin ko, aling bisphosphonate ang pwedeng maibigay sa patients na may uncontrolled GERD with peptic strictures. Okay, so that hindi ka na mako-confuse. Problema kasi, pag di mo to ginawa, pwede nyo rin naman dito gawin, no? Pero ang problema, pag di nyo to ginawa, it will take you so much time and energy para pumili ng options. As we know, 2 hours na yung exam. Tas 100 items, no? Anyway, alin ang pwedeng ibigay sa may peptic strictures? The correct answer is zoledronic acid. Why? Actually, madali lang yung reason niya. It's because zoledronic acid is the only bisphosphonate na IV ang administration, as you can see here. So this is a screenshot from Harrison's. Zoledronic acid is a potent bisphosphonate with a unique administration regimen, which is IV infusion. The others are tablet form. Okay? Sinabi rin sa Harrison's na because of the potential for esophageal irritation, alendronate is contraindicated in patients who have stricture or inadequate emptying of the esophagus. Okay? That is why, ito mahalaga rin yung kasunod na sentence pero hindi ko na highlight. Kaya nga pag nag-take ng bisphosphonates ang patient, they should be standing or sitting upright for at least 30 minutes after taking the medication. Okay? To avoid esophageal irritation, and that food and fluids be avoided for the same duration. Okay, no food and fluids other than water 30 minutes after taking alendronate, no? And the patient should be sitting upright or standing. Okay, to avoid esophageal irritation. Okay, so that's all for GERD. Now let's go to PUD. Now, PUD, a 30-year-old male complains of recurrent upper abdominal pain, burning in character, occasionally awakening him at night. Okay? Take note, awakening him at night, burning in character. During the day, his pain is more noted when meals are delayed and is relieved minutes after food intake. Denies weight loss, evidence of gross GI bleeding, but admits to occasional taking OTC meds for his migraine. What is the most likely diagnosis? Well, again, nasa topic tayo ng PUD, so the most likely diagnosis is PUD. Pero may dalawa kasing klase ng PUD. We have gastric ulcer and duodenal ulcer. But, nagkakaiba sila sa signs and symptoms. Dahil itong PUD na to is relieved by food intake, the most likely diagnosis is duodenal ulcer because ang gastric ulcer is worsened by food intake. And another thing is that ang duodenal ulcer awakens the patient at night. As you will see later, we will discuss that. Okay? So what is the next best step sa patient na may PUD? The correct answer is H. pylori testing. Okay? We have an algorithm that I will show you in the next following slides. Kung paano isipin yung kung anong test ang kasunod na gagawin sa patient na may dyspepsia or PUD. Paano naman kung may unexplained weight loss? Upper endoscopy. So, nakita nyo, parang may pattern, no? Sa GERD, pag may alarm symptom, is upper endoscopy agad. Sa PUD, actually, ang unexplained weight loss sa PUD is also an alarm symptom, which also leads you to do upper endoscopy agad. Okay? Okay. So, as I said, meron tayong duodenal and gastric ulcer. And in terms of character of abdominal pain, ang duodenal ulcer has that character of pain that awakens the patient from sleep, which is the most discriminating symptom of duodenal ulcer. Okay? So, yun yung sinabi kanina dito sa ating question stem, awakening him at night. So, that is duodenal ulcer. Ang characteristic ng gastric ulcer, wala siyang ganon, na gumigising sa patient from sleep. Okay, walang ganun sa gastric ulcer. And duodenal ulcer is relieved by food. Ang gastric ulcer is precipitated by food, as I said earlier. Okay? And, pero pag ang question is, alin sa duodenal versus gastric ulcer yung more commonly associated with malignancy, the correct answer is gastric ulcer. Gastric ulcer is more associated with malignancy, which is why all gastric ulcers should be biopsied. Okay? So, sa duodenal ulcer, hindi lahat kailangan i-biopsy. Pag may mga on endoscopy, pag may nakita lang sa endoscopy sa duodenal ulcer na parang mga signs na or mga appearance ng duodenal ulcer that point to a possible malignancy, that's the time na ibabiopsy yung duodenal ulcer. But in gastric ulcer, kahit ano pa yung tsura niya, ibabiopsy yan kasi there's an increased risk of malignancy. Okay? Excuse me. So, saan galing? What is the etiology of PUD? There are two most common etiologies amongst others, H. pylori and NSAIDs. Okay? And the mode of transmission of H. pylori is oral-oral or fecal-oral route. Okay? And the risk factors are poor socioeconomic status, crowded and sanitary conditions, and low educational attainment. In these conditions, very prevalent ang ganitong route of transmission of bacteria. Okay? And then another etiologic factor is NSAIDs. Okay? Which is dun sa ating patient kanina, di ba? Sabi niya is nagtitake siya ng OTC medications for migraine. Okay? So, in order to diagnose patients with possible PUD, this is the algorithm from Harrison's. So, if the patient has a new onset dyspepsia is yung parang yung epigastric pain, no? That's the description of it. And the patient is more than 40 years old and my alarm symptoms. Okay? Ano yung alarm symptoms? One of the alarm symptoms is One of the alarm symptoms is pag yung patient is may unexplained weight loss. Pag meron siya more than 40 years old na new onset dyspepsia and may alarm symptoms, pag positive siya doon, refer to gastroenterologist ang gagawin mo for upper endoscopy. Kasi yun yung sagot dun, kaya yun ang sagot dun sa ating question stem kanina. Now, kung hindi siya 40 years old, okay, tulad nung, okay, itong patient natin is 30 years old, okay. So, kung hindi siya 40 years old, patient natin 30 years old, and wala siyang alarm symptoms, tulad ng patient natin, walang alarm symptoms, kasi sabi niya, wala siyang weight loss, wala siyang gross GI bleeding, dahil negative siya dyan, which is why ang next step is non-invasive H. pylori testing. Okay? Yun yung sagot kanina, di ba? Next best step, H. pylori testing. Now, after H. pylori testing and wala kang nakitang H. pylori, empiric H2 blocker. Pero pag may nakita kang H. pylori sa non-invasive H. pylori testing, ang gagawin mo pag positive sa H. pylori is to give anti-H. pylori therapy in the form of OCA therapy or OCM therapy. OCA is omeprazole, clarithromycin, amoxicillin. OCM is omeprazole, clarithromycin, and metronidazole. Okay? And then remember this, guys, yung number na to, 4 weeks after therapy. Okay, 4 weeks after therapy ng H. pylori, ng OCA or OCM, pero may iba ring mga marami ring ibang regimens for H. pylori. 4 weeks after therapy, you should confirm the eradication by using UBT, urea breath test. We will discuss that in a while. Okay, so here are the tests for H. pylori. Okay, mahalaga tong table na to, makikita nyo sa Harrison's. Meron tayong dalawang tests, invasive and non-invasive. Okay? Now, ang kailangan nyo tandaan dito is ang ginagamit natin, ang kailangan nyo tandaan dito is kung ano yung most convenient pag may tanong na most convenient. Okay, dito muna tayo sa gold standard. The gold standard test for PUD is histologic evaluation of the endoscopic biopsy. Okay? Histologic evaluation ng biopsy. But the most convenient is UBT. Okay? This is the most convenient. Urea breath test. And then the test of choice to document H. pylori eradication is UBT or stool antigen. Ito yung pang test kung may eradication of H. pylori is UBT or stool antigen. Ngayon, ano pa yung mahalaga dito sa table na to? There are 2 tests dito sa table na to that can be false negative ang sagot. Na pwedeng false negative ang result after the recent use of PPI or antibiotics. As you can see, pwedeng maging false negative ang result nitong rapid urease test pag may recent use of PPIs, recent use of antibiotics, or bismuth compounds. It's the same thing with urea breath test. Pwede rin siya maging false negative with recent therapy. So, paano nyo matatandaan yun? Dito sa 6 na to, dito sa 6 na tests na to, yung pwedeng magkaroon ng false negative with recent therapy is yung dalawang test na may pangalan na urea dun sa kanilang name. No? So, urea breath test, rapid urease. Okay? Urea breath test and rapid urea breath test and rapid urease. Okay? Sila yung pwedeng maging false negative with recent use of PPIs, antibiotics, or bismuth compounds. Okay? Okay, so the problem with culture, which is the problem with culture is it is very time consuming and expensive. And ito namang histology, which is the gold standard, histologic evaluation. It requires pathology processing and staining, provides histologic confirmation. Okay? So that is the gold standard, pero matagal din kasi yun. For the treatment, Okay? For the treatment, the most potent for the treatment ng PUD is PPI. Pwede rin tayo mag-H2RAs or H2 receptor antagonists in the form of ranitidine, mga ganon, famotidine, but the patient may develop tachyphylaxis. So what's tachyphylaxis? It means the efficacy of the drug ay nagde-decrease as with succeeding doses of that drug. So that's tachyphylaxis, no? Which is why it's not the most potent. PPI is the most potent. And then we also, so this is for acid neutralizing therapy, yung mga PPI H2RAs. Antacids, it's rarely used now. Okay? How about H. pylori therapy? We should use, dahil ang H. pylori is a gram-negative organism, it's a bacteria, that's why we are using antibiotics. It can either be OCA, OCM, the amoxicillin is replaced with metronidazole sa OCM, or there are other regimens such as TUMB, okay? Tetracycline, omeprazole, metronidazole, and bismuth. Now, itong OCA or TUMB, you will give it for 14 days. 14 days, okay? After ng 14 days ng OCA, another 4 to 6 weeks of PPI only. Okay, tanda, okay? 14 days of OCA, and then after that, ng 14 days of OCA or 2 weeks, 2 weeks of OCA, after that, another 4 to 6 weeks of O lang, omeprazole lang. Okay? Yun na ibig sabihin nun. And then after ng 4 to 6 weeks of O lang or omeprazole lang, bibilang ka ng 4 weeks, after mo matapos yung course na yun, bibilang ka ng 4 weeks, that's the time na i-document mo yung eradication ng H. pylori using UBT or stool antigen. Okay, tandaan niyo, bakit po mahalaga yung 4 weeks? Kasi for the past PLEs, nagbibigay na sila ng mga numbers, okay? Yun yung reklamo ng mga nag-PLE noong March 2023. For example, may questions daw about how many weeks after giving treatment for hyperthyroidism, after how many weeks ka magte-test ng FT4, okay, levels. And then meron din question about hypothyroidism, how many weeks after initiating treatment for hypothyroidism in the form of levothyroxine, how many weeks after initiating treatment should you check for TSH? Tandaan niyo, okay, medyo nagsisegue na ako. Pero sinasabi ko yun kasi for example, dun sa after mo mag-start ng treatment for hyperthyroidism, kung nagbigay ka ng methimazole, you should check the FT4 4 to 6 weeks after initiating treatment. You will measure FT4. Okay, that's for hyperthyroidism. For hypothyroidism, you will, after initiating treatment with levothyroxine, you will check TSH levels after 2 months or 8 weeks. Okay, 4 to 6 weeks sa hyperthyroidism, 8 weeks or 2 months sa hypothyroidism. Sa hyperthyroidism, you will check the FT4. Sa hypothyroidism, you will check the TSH. Okay? Bakit ako nagsasabi ng ganun? Kasi nga tinanong na sa previous PLE, yung number of weeks after initiating treatment, kailangan magte-test. Okay, so pwedeng hindi na lumabas yun, yung kung ilang weeks after sa hyperthyroidism and ilang weeks after initiating treatment sa hypothyroidism, pwedeng hindi na siya lumabas. Pero the point is, nagtatanong na sila ng numbers. So which is why, kailangan nyo malaman yung 4 weeks after the treatment course ng OCA or ng O, for a total of 4 to 6 weeks. 4 weeks after that, magte-test ka ng H. pylori eradication. Okay? Okay, so PUD, ang mga goals natin, treat underlying cause with H. pylori therapy, discuss na natin, promote ulcer healing with PPI, misoprostol, prevent recurrence. Complications of PUD. Now, there are 3 complications of PUD. BPO. Okay? Business process outsourcing, yung mga BPO na mga nasa corporate field. Okay, BPO. The most common is kung ano yung B. The most common is B dito sa BPO, bleeding, perforation, obstruction. Yet those are the complications of PUD, and the most common sa BPO is si B. Si bleeding is the most common. The least common is O, obstruction. Okay? So there are 2 kinds of general buckets of GI bleeding. We have overt GI bleeding and we have occult GI bleeding. So overt GI bleeding is obvious. GI bleeding manifested by hematemesis, vomitus of red blood or coffee grounds material. We also have occult GI bleeding, which is hidden na GI bleeding. Na nagpe-present lang with symptoms of anemia like lightheadedness, syncope, angina, or dyspnea. Now, melena indicates blood is present in the GIT for at least 14 hours or as long as 3 to 5 days. Again, tandaan nyo yung numbers. Okay? Now, hematochezia is not always saying na lower GI source yung bleeding. It can also mean na yung bleeding is coming from the upper GI bleeding. It's just that sa sobrang severe and excessive yung GI bleeding sa upper GI is it hasn't had enough time, which is at least 14 hours, to become dark in color yung bleeding from the upper GI, which is melena. Hindi na siya naglalas ng 14 hours dahil sobrang daming bleeding. It stimulates the peristalsis of the gastrointestinal tract, leading to its expulsion in the form of feces and hematochezia. Okay. So what are some of the clues for upper GI bleeding? Hyperactive bowel sounds, high BUN due to volume depletion, absorption of blood protein in the small intestine. So pag upper GI bleeding, the sign usually is melena, black tarry stool, but it can also be hematochezia if massive yung bleeding from the upper GI. The most common etiology is peptic ulcers. However, sa lower GI, hematochezia naman ang sign commonly. And overall, tandaan nyo, hemorrhoids ang most common etiology ng lower GI bleeding. Okay? We will discuss later kasi may mga sa Harrison sinabi rin na pwedeng ang sagot sa most common etiology of lower GI bleeding is diverticulosis. But we will discuss it later, okay? Okay, so the management for GI bleeding is airway protection, firstly, of course, ABCs. And the hemoglobin may be normal during the first 72 hours. It may be normal or only minimally decreased. Kasi the change in hemoglobin will be observed up to 72 hours after initial bleeding event. Kasi the reason why hemoglobin is still normal within 72 hours after the initial bleed is because people bleed whole blood. Meaning, kasi di ba, the change in hemoglobin and hematocrit, kasi di ba ang hemoglobin hematocrit is parang part siya ng formed elements ng blood kasi di ba ang blood is made up of plasma and then formed elements na nasa formed elements yung white blood cell, platelet and RBC, hemoglobin. So ang hematocrit is a percentage or a ratio nung blood mismo. And what happens is when pag nagkaroon ng GI bleeding, people bleed whole blood. No, hindi naman sila nagbe-bleed ng plasma lang. So the ratio of hemoglobin dun sa blood is the same after the bleeding. So what happens is right after the bleeding, if you get the CBC, is ganun pa rin yung normal yung hemoglobin niya. But after a few days, which is up until at least 72 hours, that's the time na some of the interstitial fluid is coming inside. Parang some of the interstitial fluid is starting to go inside the blood vessels, which dilutes the blood inside the blood vessels, which is why dumadami yung plasma volume, so nadidilute yung blood, so bumababa yung ratio ng hematocrit and hemoglobin and RBCs. So kaya bumababa yung hematocrit and hemoglobin, no? Which happens at the 72 hours after the initial bleeding. Okay? And tandaan niyo, hindi lahat ng patients na nag-GI bleeding, kasi lalo na kung minimal lang, hindi lahat ay sinasalina ng dugo or nagba-blood transfusion. Blood transfusion is only recommended when the hemoglobin is less than 7 grams per deciliter or less than 70 grams per liter. Okay, why? Because may mga studies na nagpapakita na pag liberal yung transfusion strategy, kasi may dalawang groups doon, merong restrictive transfusion strategy and meron tayong liberal transfusion strategy. Doon sa liberal transfusion strategy, ibig sabihin nagba-blood transfusion sila kahit na 9 pa lang or 10 yung level ng hemoglobin. That's liberal. And meron din restrictive transfusion strategy, which is nagba-blood transfuse lang sila when the hemoglobin goes below 70 grams per liter or less than 7 grams per deciliter. And they found out na mas mataas yung mortality dun sa liberal transfusion strategy kaysa dun sa restrictive, which is why recommended yung blood transfusion only when the hemoglobin is less than 7 grams per deciliter. Na specific therapies for PUD, it's PPI drip, yung mga nakikita nyo sa during internship ng mga omeprazole drip. And if the patient has cirrhosis, which is tas nagkaroon siya ng GI bleeding, which points to the most likely cause ay bleeding esophageal varices. That's the time na magbibigay ka ng somatostatin or octreotide drip. Now, it's not recommended na pagsamahin sila, like parang broad spectrum na pagbibigay ng PPI plus somatostatin. Kasi clinically naman is makikita mo from the question stem or in real life, makikita mo naman na ano yung most likely cause ng kanyang GI bleeding. So kung for example, wala naman siyang cirrhosis, or you're less likely thinking of bleeding esophageal varices, so bibigay mo is PPI. But yun nga, pag yung patient is may cirrhosis and most likely causes bleeding esophageal varices, you'll give somatostatin or octreotide, okay? Now, so this is directly from Harrison's, quoted from Harrison's, no? The measurement of the heart rate and the blood pressure is the best way to initially assess a patient with GI bleeding, okay? So most important in acute GI bleeding is to determine the presence of hemodynamic instability. As you will see later sa algorithm for lower GI bleeding, the decision as to which kind of endoscopic procedure to do dun sa patient, it all depends on whether the patient is hemodynamically stable or not. No, as you will see maybe later, papakita natin lower GI bleed algorithm. It depends on whether the patient is hemodynamically stable or not. And then, paano natin nalalaman kung hemodynamically stable or not? Well, pwedeng through the presence of orthostatic hypotension, and which is defined as a drop in systolic pressure of more than 20 or a rise in pulse of more than 10 beats per minute. Okay, so ito, as I said kanina, you can see from the question stem kung saan nanggagaling yung GI bleeding ng patient. Tulad dito, 65-year-old na alcoholic na may massive hematemesis. And on examination, ito yung kanyang vital signs. May jaundice, may ascites, and may edema. What is the probable cause of UGIB in this case? Bleeding esophageal varices. Kasi itong question stem na to points to cirrhosis, jaundice, ascites, edema. Bleeding esophageal varices. What is the bleeding esophageal varices from the portal hypertension that is caused by cirrhosis? Okay. What is the next best step? Urgent endoscopy within 24 hours. Again, in the previous Harrison's na edition, which is the blue one, again, ang recommendation is urgent endoscopy within 12 hours. Pero binago nila dito sa red. Sabi nila, urgent endoscopy na, pwede nang gawin up until within 24 hours. Why? Because more urgent endoscopy, which is yung 12 hours in the previous recommendation, more urgent endoscopy does not improve outcomes, which is why nilengthen na nila yung urgent endoscopy definition nila to within 24 hours instead of within 12. No? What is the next step if esophageal varices are documented? The answer is endoscopic ligation and IV vasoactive medications in the form of octreotide. Okay, as I said kanina, the most common etiology of UGIB is peptic ulcers. And these are the two most common etiology, NSAIDs and H. pylori. Variceal bleeding is usually in the presence of portal hypertension. Now, tandaan nyo tong phrases na to. Pag nakita nyo dun sa question stem na yung patient is may vomiting, retching, or coughing that precedes the hematemesis, the most likely answer is Mallory-Weiss there. Especially in alcoholic patient. Parang, ang usual na question stem niyan ay patient na pumunta sa ER for hematemesis na hematemesis after niya magkaroon ng vomiting, retching, and coughing dahil nag-alcoholic binge daw siya the night before. So yun yung parang usual na question stem ng Mallory-Weiss there. And And pag ganun yung nakita nyo yung questions 10, the most likely answer is Mallory-Weiss there. Okay? Again, numbers. Tandaan nyo tong number na to. Kasi tinanong siya sa last PLE, March 2023 or October 2022. Tinanong ang definition ng gaano kalalim or gaano kalalim ang depth ng isang ulcer. Okay? The answer is more than 5 millimeters. Ulcer is a break in the mucosa of more than 5 millimeters. Okay? Ulcer definition is more than 5. Okay? Tandaan nyo yan. So this is an algorithm from Harrison's. It depends. So dito muna tayo sa ulcer. As you can see, it's differentiated by the colors, no? Punta tayo dito sa green one. Okay. So, yung treatment mo for each of the yung treatment mo may differ depending on the endoscopic feature of the ulcer. So, if it's actively bleeding or visible bleeding, you will do endoscopic therapy and you will do intensive PPI therapy. The definition of intensive PPI therapy is you will do omeprazole drip, IV PPI drip, no? Or omeprazole PPI drip or omeprazole drip or omeprazole na every 12 hours. Yun yung tinatawag nila intensive PPI. And then kung actively bleeding or visible vessel, okay, nakikita nyo yung omeprazole drip sa internship, di ba? And then after ng intensive PPI therapy, you also do simultaneously you will do clear liquids for 2 days and the hospitalized for 3 days. On the opposite side of the spectrum, kung clean base siya, meaning wala talagang bleeding, you will not do any endoscopic therapy. Magiging omeprazole once a day lang siya. Regular diet na agad, walang clear liquids, and discharge na after endoscopy. Okay, so it really depends on the endoscopic feature ng ulcer. How about kung esophageal varices? You will do endoscopic vasodilation. Hindi ka magpi-PPI pag varices. You will give vasoactive drugs in the form of octreotide and clear liquids, hospitalized for 3 to 5 days. Excuse me. How about kung Mallory-Weiss there? We have can either be active bleeding or no active bleeding. And as you can see, there are some similarities sa itsura nung parang algorithm. Kasi tinan mo, kung no active bleeding ang Mallory-Weiss there, sa regular diet, discharge after endoscopy. So it's almost the same as the second half nitong algorithm for a clean base. Okay, na ulcer. It's also sa erosions, no endoscopic therapy, once daily, regular diet, discharge after endoscopy pag erosions. Tingnan nyo, ito ay similar talaga sa itsura ng clean base ng ulcer. Okay, so there's some similarities, so huwag kayong malilito, no? So I'll just leave this up to you to read on. Let's go to lower GI bleeding. 68-year-old man with no comorbids brought to the ER after passing fresh blood per rectum. No abdominal pain. Okay? No abdominal pain. Mahalaga yan. Okay? BP is 80/50, tachycardic. Okay? No stigmata of cirrhosis. Fresh blood per examining finger, hematochezia. What is the best next step? The correct answer is upper endoscopy. Okay. Papakita natin mamaya sa algorithm kung bakit. But in a patient with hematochezia, based sa DRE, and unstable yung patient, hemodynamically unstable, meaning mababa yung BP, less than 90/60, sa patient is 80/50, tachycardic pa, most likely meron ding orthostatic hypotension, but it was not mentioned in the STEM. So hematochezia plus hemodynamically unstable patient, you should first do upper endoscopy to rule out upper GI bleeding. Because as we said kanina, pag ang patient is may upper GI bleeding usually presents with melena, but if the upper GI bleeding is so severe, it can also present with hematochezia. Now, if the EJD is normal, which is the upper endoscopy, what is the most likely etiology of LGIB? The correct answer is diverticular disease. Pero teka lang, sabi natin dun sa slides kanina, the most common etiology of lower GI bleeding is hemorrhoids. Bakit dito diverticular disease na? Kasi, ang sabi sa Harrison's, overall, the most common etiology of lower GI bleeding is hemorrhoids, overall. But, if local anal processes are excluded, which kasi kasama dun sa local anal processes ay hemorrhoids. If local anal processes are excluded, which rarely require hospitalization, the most common etiology of lower GI bleeding is diverticular disease. In other words, if tinanggal mo yung mga local anal processes tulad ng hemorrhoids, na kasi yung hemorrhoids naman is hindi naman kailangang mo hospital, di ba? Hindi ka naman pumupunta sa hospital para dahil sa hemorrhoids mo. Pag inalis mo yon, the most common diagnosis na ng the most likely etiology ng lower GI bleed are diverticular disease. Okay, which is why the most likely etiology of LGIB in this case is diverticular disease, no? Ulitin ko, if overall, hemorrhoids, pero pag tinanggal mo yung hemorrhoids, diverticular disease ang most common etiology of LGIB. What is the characteristic bleeding of diverticular bleeding? Abrupt in onset, painless. Kaya natin in-underline yung denies any abdominal pain. Kasi ang pain ng diverticular bleeding is massive, painless, lower GI bleeding. Okay, yun yung characteristic bleeding ng diverticular bleeding. LGIB etiologies, diverticular disease is the most common. As I said kanina, abrupt in onset, painless, sometimes massive. Pero overall is hemorrhoids. If local anal processes are excluded, which rarely require hospitalization, diverticular disease is the most common etiology of LGIB. Okay, ito yung sinasabi ko na algorithm for LGIB. Na it depends sa hemodynamic status ng patient kung ano yung gagawin mo muna. Sa patient natin kanina is may LGIB siya, lower GI bleeding, and siya ay hemodynamically unstable because yung kanyang BP is 80/50 and the heart rate is 120, which is tachycardic. So since hemodynamically unstable yung patient, the first step is upper endoscopy. Now, kung wala kang makitang upper GI source of bleeding and the patient is too unstable to prep, meaning unstable pa rin yung kanyang blood vital signs, you will do angiography. Okay? Now, if the bleeding still persists, you will do surgery. Okay, ganun yung step-by-step na way of doing about it, no? But if sa upper endoscopy, there's no upper GI source, pero nag-stabilize na yung patient, and then you can go na to colonoscopy instead of going to angiography. You will only do angiography if the patient is too unstable to prep, as you can see here, no? Now, it's a slightly different thing kung hemodynamically stable yung patient. Kasi dito, no instability. So, meaning hemodynamically stable. Now, if the patient is hemodynamically stable, ang first question is ano yung age? Kasi if the age is less than 40 years, pwede ka mag-flexible sigmoidoscopy. But if the patient is less than 40 years, pero copious yung bleeding and may family history of colon cancer, you go straight to colonoscopy. Why? Kahit na age, kasi ang flexible sigmoidoscopy, as the name suggests, is the scope goes until sa sigmoid lang. No, kung colonoscopy, it goes as far as yung right side of the colon. So, if yung patient is make more copious bleeding and may family history of colon cancer, baka meron din siyang personal na history ng colon cancer na hindi pa natin na-detect. So, we have to go through all the way to the right side of the colon to see and make sure na wala siyang colon cancer. That is why colonoscopy is suggested if may have family history of colon cancer. But if the age is more than equal 40 years, you go straight to colonoscopy. Okay? Okay, so you can find this in yung handouts. Most common causes of LGIB, nasabi natin kanina. Most common cause of significant lower GI bleed in children is Meckel's diverticulum. I'll just leave this to you to read on your own. Okay, let's go to cirrhosis. Cirrhosis is the end result of chronic liver injury leading to fibrous nodular regeneration. Now, the reason why sa mga patients na may cirrhosis, meron silang spider angioma and pulmonary edema is dahil may hyperestrogenism or hyperestrogenism. The reason is dahil in cirrhosis, dahil decrease na yung functional liver to metabolize these kinds of hormones like yung estrogen. The estrogen, nagkakaroon ng estrogen accumulation in the blood. And what happens is ang estrogen kasi is vasodilator siya. So, nagdadilate siya ng vessels in the skin leading to spider angiomas, blood vessels in the palms leading to pulmonary edema, gynecomastia and testicular atrophy, well, dahil siya ay estrogen. No? And again, paalalahanin nyo yung number. Portal hypertension is defined as elevation of HAV-PG or hepatic venous pressure gradient of more than 5 mmHg. That's the definition of portal hypertension. These are some of the causes of cirrhosis, as you can see. Okay. Complications of cirrhosis. This is important kasi this is important. Ang dalawang important dito is yung hepatorenal syndrome and hepatopulmonary syndrome. But all of this is important naman. You should only pero in this slide you should be able to distinguish between type 1 and type 2 HRS or hepatorenal syndrome. Type 1 HRS is the more serious form, hepatorenal syndrome. Type 1 is the more serious form, which and AKI or acute kidney injury occurs in less than 2 weeks, mostly with oliguria. That's the type 1 HRS. The type 2 HRS is less severe than the type 1. Hepatopulmonary syndrome naman, dyan nangyayari yung phenomenon of platypnea and orthodeoxia. Kasi normally, di ba, pag sa patient na may heart failure, nagkakaroon sila ng dyspnea when they lie flat. Okay? And they also have O2 desaturation when they lie flat sa mga patients na may heart failure. Sa patients na may hepatopulmonary syndrome, it's the opposite. It's the opposite that happens. Ang nangyayari, nagkakaroon sila ng desaturation, nagkakaroon sila ng dyspnea when they position themselves upright. Okay? Sa patients na may hepatopulmonary syndrome, nagkakaroon sila ng dyspnea when they assume the upright position. Ang tawag doon is platypnea. And they also experience desaturation when they position themselves upright ulit. Okay? So, ang tawag naman doon is orthodeoxia. Okay? So, platypnea and orthodeoxia, they happen in hepatopulmonary syndrome. There are 3 classifications of portal hypertension. Can either be prehepatic, hepatic, and posthepatic. The reason lang na ito yung names nila is, di ba, based sa anong vessels yung involved in relation to the liver. Kasi di ba kunwari ito yung liver, tapos ito yung portal vein, di ba? It comes from here. Dinedrain niya yung blood coming from the intestines papunta din sa liver, and then mag-exit dito sa hepatic vein. Diba? Papunta na to dun sa heart. Kuwari ito yung heart, diba? Okay. So, prehepatic causes of portal hypertension can be portal vein thrombosis. Pag nagkaroon ng thrombosis dito, portal vein kasi ito. Splenic vein thrombosis kasi di ba what forms the portal vein are the superior mesenteric vein, superior mesenteric vein, splenic vein, and it is joined by the inferior mesenteric vein. So, splenic vein thrombosis, which is dito rin, prehepatic din siya, and Banti syndrome. Post-hepatic na portal causes of hypertension is pag may inferior vena caval webs kasi di ba after the hepatic vein is nandito na rin yung IVC or yung inferior vena cava. So pag may webs dyan, post-hepatic cause of portal hypertension yun. It can also be restrictive cardiomyopathy kasi post-hepatic ang location ng heart, which is pag nagkaroon ng RCM dito, which restrictive yung pericardium that surrounds the heart. It causes the buildup of pressure, and then the pressure backs up through the inferior vena cava and papunta sa hepatic vein. So, post-hepatic cause din siya ng portal hypertension. And then we also have hepatic causes of portal hypertension. Pero mahalaga dito, dahil ito yung sikat sa Pinas, is schistosomiasis. Okay, so tandaan ninyo, ang schistosomiasis is, classification is hepatic na portal hypertension and pre-sinusoidal. Okay, hepatic, pre-sinusoidal, schistosomiasis. Okay, there are other causes kasi ng hepatic. They can also be sinusoidal and post-sinusoidal, pero pre-sinusoidal si schistosomiasis. Clinical manifestations, I'll just leave this to you to read on. Na-discuss na natin itong dalawang to, testicular atrophic gynecomastia, RUQ pain, GI bleeding, jaundice, encephalopathy. So diagnostic features, it can be anemia, reduced platelets and white count. Can also be deranged na INR and albumin. INR kasi pag deranged ng INR, it can lead to bleeding. Okay? The reason is, kasi di ba, most clotting factors are produced in the liver. Except for what clotting factor? Clotting factor 8. Kasi clotting factor 8 is produced in the blood vessels. Okay? All clotting factors are synthesized in the liver except for clotting factor 8. Okay. So, labs may be normal. Loss of hepatocellular function results in coagulation disorders. Nagkaroon ng excessive bleeding. And hypoalbuminemia kasi albumin is also synthesized in the liver. Now, tandaan ninyo, 3 primary complications of portal hypertension is VA. VA. Okay, varices, ascites, hypersplenism. Hypersplenism. Okay, VA. Kasi there are other complications of portal hypertension, of cirrhosis. There are other complications. Ano yung other complications? SBP, osteomalacia, osteoporosis. There are other complications, but the 3 primary complications are VA, varices, ascites, hypersplenism. Management. Sa management, napakaraming management ng cirrhosis, but you should only remember, para matandaan niyo, tandaan niyo muna yung mnemonic ng VIBES. V for volume, I, infection, bleeding, encephalopathy, and screening. Volume is, dahil ang patients na may fluid overload ng mga patients na may cirrhosis. So, you have to be wary, and nagkakaroon ng ascites yung mga patients na may cirrhosis. So, that's volume. So, for ascites, you should do sodium restriction. I think that's less than 2 grams per day, sodium restriction. You should also give diuretics in the form of furospiro, furosemide, spironolactone. Okay, in the ratio of 2:5. Ano yung sabihin nun? Ibig sabihin nun is, that's the reason kung bakit during your internship, nakakita kayo ng patients na may cirrhosis na ang binibigay nila is furospiro, furosemide, spironolactone in the ratio of 2:5, or furosemide 40 mg and spironolactone 100 mg. The ratio of that is 2:5. So, bakit kailangan dagdagan ng spironolactone yung furo? Kasi, ang furo kasi is a loop diuretic that inhibits the sodium, potassium, 2-chloride na channel sa loop of Henle. At yun ang site of action ng furosemide, di ba? So, kung ini-inhibit niya nun, maliban sa inhibiting the reabsorption of sodium, it also inhibits the reabsorption of potassium, which means that potassium gets excreted into the urine, which means that there's a chance na magkakaroon ng hypokalemia. And remember, one of the precipitating factors for hepatic encephalopathy is hypokalemia, low potassium, which is why ang mga patients na binibigyan natin ng furosemide spironolactone is binibigyan ng diuretics is may spironolactone, because spironolactone is it leads to potassium conservation, no? It leads to yung potassium is getting reabsorbed into the blood. So the addition of spironolactone, which is an aldosterone antagonist, the addition of spironolactone prevents the adverse effect of hypokalemia, which means hindi magkakaroon ng hypokalemia yung patient, so meaning less likely na matitrigger yung kanyang hepatic encephalopathy. Okay? So, kailangan ma-maintain natin yung normal levels of potassium in patients with cirrhosis, furospiro. And if the diuretics do not work, that's the time na magpaparacentesis. Okay? So, that's for volume. Now, we go to infection. So, sa infection, dahil in patients with ascites from cirrhosis, there could be the complication of spontaneous bacterial peritonitis, of which the most common etiologic factor is I think E. coli, no? And that is why, dahil gram-negative organism ang E. coli, that is why ang treatment is IV third-generation cephalosporin for 5 days. Okay? Now, another is bleeding. Bleeding, we can prevent bleeding and we can also solve the bleeding. No, we can prevent bleeding, but from the esophageal varices brought about by portal hypertension from cirrhosis, if we give primary prophylaxis. So, pag sinabing primary prophylaxis, wala pa siyang bleeding, at any time in the past, no? Yun ang sabi ng primary prophylaxis. And what we give to those patients is propranolol or nadolol. Wala nang ibang sinabing effective na beta blocker kundi propranolol or nadolol. Ang reason nito is ang goal mo pag nagbigay ka ng propranolol or nadolol is mayroon kang goal na heart rate of 55 to 60 and an SBP of more than 90. Okay? So, you have to maintain that goal in order to prevent the bleeding from the esophageal varices. But, pag nag-bleed na yung patient, secondary prophylaxis na yung ginagawa. Meaning kasi nga, nag-bleed na siya. So, ang ginagawa natin, RBL, or pag hindi nag-work ito, TIPS, no? And then we also have encephalopathy. Treatment and prevention for hepatic encephalopathy is lactulose. So ang ginagawa kasi ng lactulose kasi is it promotes colonic acidification. So what happens is yung ammonia kasi 'di ba ang isa sa mga reasons kung bakit nagkaroon ng hepatic encephalopathy is increased amounts of ammonia. Okay? So ang goal natin is ma-prevent na yung build-up ng ammonia in the blood. So dun sa stomach, meron dong ammonia. Okay? Ang ammonia is non-polar, lipid-soluble. Okay? Which means ammonia is uncharged, non-polar, lipid-soluble. Meaning it can cross through cell membranes from the lumen of the small intestine or from the lumen of the colon. The ammonia can pass through the cell membranes and go to the blood, and from the blood go to the brain, leading to hepatic encephalopathy. So the goal is matrap natin si ammonia sa loob ng na colon. Yun ang yung goal. Enter lactulose. Ang ginagawa ni lactulose, binibigyan niya ng hydrogen si ammonia. Si ammonia na NH3, which is non-polar, lipid-soluble, uncharged, is pag binigyan ni lactulose ng hydrogen si ammonia, si NH3 ammonia magiging ammonium NH4+. So, si ammonium na NH4+ is now water-soluble, polar, and charged. Meaning, water-soluble siya, meaning hindi na siya magkocross through cell membranes. Meaning, hindi na siya pupunta sa blood. Meaning, hindi na siya pupunta sa brain. Meaning, trapped siya sa loob ng colon. Meaning, water-soluble nga, may excrete siya with the feces. So, bababa yung total ammonium load mo sa body. So, ganun ka-effective si lactulose. No? Ang tawag doon colonic acidification kasi nagbibigay nga ng hydrogen si lactulose kay ammonia para maging ammonium and maging water-soluble, charged, and polar si ammonia. Okay, so that's NSF. Screening is screening for hepatitis. That's why sa mga patients with cirrhosis, nagsiscreen tayo ng Hep profile, Hep B, Hep C, ganun. And we also do ultrasound screening for HCCA or hepatocellular carcinoma. Beta blockers lowers the portal pressure to prevent esophageal bleeding. Tips, transjugular intrahepatic portal systemic shunt. For acute decompression lang ito ng portal hypertension if all else fails. If all else fails, like nag-fail yung endoscopic and medical management. Okay, approach to ascites. Oops, may sagot na. 40-year-old male, heavy alcoholic, sought consult for abdominal enlargement, abdominal pain, flanks were bulging. Percussion findings are tympanitic over the umbilicus but dull on the lateral abdomen. So the reason kung bakit dull siya on the lateral abdomen, tympanitic siya over the umbilicus kasi may gas doon. Pero which is normal finding, but the abnormal finding is the dull percussion finding on the lateral abdomen. The reason for the dullness is nandun kasi yung fluid, no? So, If the ultrasound confirmed na ascites yung abdominal enlargement ng patient, what is your next step? The correct answer is paracentesis. Which side? LLQ, or left lower quadrant. What's the reason? Because the left lower quadrant is of greater depth. Doon mas malalim yung ascites as they found. There's a greater depth of ascites and the abdominal wall is thinner on the left lower quadrant. Kaya sa left lower quadrant tayo usually nagawa na paracentesis. What is the most common cause of ascites? It's liver cirrhosis. And yep, as I said kanina, restriction of sodium intake is 2 grams per day lang. Again, remember the 2 grams, okay? Now, in order to, after you get the acidic fluid after the paracentesis, you will do saag na you will test for SAAG or serum ascites albumin gradient to distinguish whether it is it's portal hypertension or non-portal hypertension. So, masasabi mo na portal hypertension if the SAAG is more than equal 1.1 and it's not portal hypertension if the SAAG is less than 1.1. So, paano nyo matatandaan to? Portal hypertension, tinan nyo, if the SAAG is higher than 1.1, if the SAAG is higher than 1.1, it's portal hypertension, okay? But if it's less than 1.1, it's not hypertension, not portal hypertension. Okay. So, paano ba kino-compute yung SAAG? So, ang gagawin nyo lang dyan, i-follow nyo lang naman yung name. Serum ascites, albumin gradient. So, kukunin nyo yung serum albumin, kukunin nyo yung serum albumin, and kukunin nyo yung acetic albumin. Tapos, ipapag-minus nyo lang. Pero make sure na parehas yung unit nila na grams per dl. Minsan kasi yung mga labs is magkaiba yung unit, no? So, if the SAAG is higher than 1.1, it's portal hypertension. Pero ang kahalagahan kasi na SAAG is it narrows down your set of differentials. Kasi if it weren't for SAAG, ito lahat yung differentials mo. Pero because of SAAG, if the SAAG is less than 1.1, ito na lang yung iisipin mong differentials. If the SAAG is higher than 1.1, it's portal hypertension. So meaning ito na lang ang iyong pagpipilian na differentials. Okay? But after mo malaman na portal hypertension yun, you still have to determine the acidic protein if it's less than 2.5 or more than equal 2.5. Okay? So, if the acidic protein is less than 2.5, meaning it could either be cirrhosis, late would carry, or massive liver metastasis. The reason for that is, if it's portal hypertension and the acidic protein is less than 2.5, the reason na less than 2.5 yan, meaning yung protein, hindi na siya maka-escape from the blood vessels, kaya mababa yung acidic protein niya. Hindi maka-escape yung protein papunta sa acidic fluid. Okay? Natatrap siya sa loob ng blood vessels, hindi siya maka-escape through that dahil sa massive liver metastasis or pwede rin dahil sa cirrhosis or dahil sa late blood carrier syndrome, hindi siya maka-escape, so mababa relatively yung acidic protein. Whereas pag yung acidic protein is more than equal 2.5, meaning walang nakaharang na liver mets o walang nakaharang na fibrous nodules in the form of cirrhosis, kaya nakakalabas pa yung acidic protein from the blood vessels, which is why ito yung differentials mo if the acidic protein is more than equal 2.5. Okay. Now, there are other findings, gross findings ng acidic fluid. If it's turbid, it could be from an infection. If it's black, it's pancreatic necrosis. If it's white milky fluid with a triglyceride level of more than 200, it could be chylous ascites. I'll just leave this to you para i-study, no, on your own. But actually, yung determination of the SAAG, that is not it's not the gold standard for diagnosis of ascites. Laparotomy or laparoscopy is. With peritoneal biopsy is the gold standard. But it's only done when the cause of ascites is uncertain, even after doing the paracentesis with SAAG determination. No? Kung ascites etiology is uncertain, that's the time na laparotomy ka or laparoscopy. Next question. A 58-year-old man presents with dull epigastric pain that has progressively worsened over the last 3 days. The pain is described to be radiating to the back. Okay, with malaise, nausea, and vomiting. Drinks 1 to 2 bottles of beer 3 to 4 times a week. So those are the pertinent positives. Distended abdomen with direct tenderness in the epigastric region. The rest of the PE was unremarkable. The most likely is acute pancreatitis. Teka lang, Doc. Bakit agad acute pancreatitis is the most likely diagnosis? Well, actually, kung epigastric pain kasi yan, there could be a lot of other differentials. Could be PUD. That's an epigastric yun. Pwede rin na abdominal aortic dissection. Those are some of the differentials. But, tandaan nyo, walang sinabi sa question stem na it awakens the patient at night, and walang sinabi na it's worsened by food, which is gastric ulcer, or it's relieved by food, which is duodenal ulcer. And it doesn't say anything about that may pulsating mass sa epigastrium. So, all of the information in the question stem point us towards the most likely diagnosis of acute pancreatitis, no? Which is radiating to the back. Paano kung radiating to the back in chest pain? Aortic dissection. Tearing knife-like chest pain that radiates to the back in between the in between the shoulder blades is aortic dissection, no? So the most likely diagnosis is acute pancreatitis, and the next best step to support the diagnosis is serum lipase. Why? Because serum lipase is more specific than serum amylase. Okay. Now, the night of the patient's admission, you notice an area of discoloration in the periumbilical area. What is this likely finding? The correct answer is Cullen's sign. Meron tayong Great Turner's sign. So, paano nyo ma-differentiate yun? So, tinan mo, periumbilical area, what is the likely finding? Cullen's sign. Cullen starts with C. Center of the abdomen is umbilicus, no? Periumbilical. So if there's an area of discoloration in the periumbilical area, which is around the center of the abdomen, C. Center, C. Cullen sign. Great Turner sign is sa sides, di ba? Sa flank. Kasi para makita mo yung Great Turner sign, you have to turn to your sides, Great Turner sign, to see kung nandun yung bleeding. Great Turner sign, you turn to the side, no? What is the best diagnostic to work up the above finding? CT scan of the abdomen. But tandaan ninyo, on the first day na pumunta yung patient sa ER, hindi tayo nagre-request na CT scan, no? We only request CT scan 3 to 5 days into hospitalization when the patients are not responding to supportive care. What are you looking for in the CT scan, which is done 3 to 5 days after admission to the hospital? To look for complications such as pancreatic necrosis. How do you diagnose acute pancreatitis? You have to establish that you can establish the diagnosis of pancreatitis by if you fulfill 2 of the following 3 criteria. 2, pag na-satisfy mo yung 2 out of the 3, acute pancreatitis yun. Ano yung 2? It could be typical abdominal pain that radiates to the back. 3-fold. Tandaan nyo yung number 3. 3-fold or greater elevation in serum lipase and or amylase, and confirmatory findings on cross-sectional abdominal imaging. What is cross-sectional abdominal imaging? CT scan, no? So, 2 of the 3. Tandaan nyo yung 3-fold. Why? Kasi baka ibigay sa inyo sa exam is 2-fold lang. Okay? So, wag yung tatandaan yun. 3-fold ang para masabi na acute panc. So, total serum amylase, okay, numbers na naman. Bakit lumabas to sa October 2022? Okay? That's 1 year ago. Pwede pa rin lumabas. Kasi most commonly, ang mga lumalabas ng mga topics is from the most previous PLE. So, in your case, that's March 2023. And from a year ago, which is October 2022. The most recent 2 PLEs, yun yung most likely medyo mapipredict mo kung anong topics or concepts yung most likely lumabas. So, total serum amylase levels return to normal values after how many days? The correct answer is 3 to 7 days. So, tandaan yung number, okay? Kaya nga, ito nag-number na naman ako. Total serum amylase ay nagre-return to normal after 3 to 7 days. And the levels of lipase ay remain elevated for 7 to 14 days. Tandaan nyo yung numbers, guys. Actually, ito yung talagang kinaiinisan ng mga student na pumasa pa rin naman noong March 2023 na kasi ang dami daw numbers, no? Now, out of all the signs and symptoms of acute pancreatitis, the major symptom is abdominal pain, no? And the leading cause is acute pancreatitis followed by alcohol. Kaya nga ang risk factors ng ng acute pancreatitis, ang kanyang is gated, no? Gated yung acronym. Makikita niyo yan sa IM plot. Gallstone, alcohol, triglyceridemia, nalimutan ko na yung ED, no? Pero mahalaga diyan, the leading cause is acute pancreatitis, no? Hypertriglyceridemia can cause acute panc, but only if the levels is more than 1,000 milligrams per deciliter. Now, what is the most important treatment intervention for acute panc? Early aggressive fluid resuscitation. No antibiotics. There's no place for prophylactic antibiotics in acute pancreatitis. No place, okay? For prophylactic antibiotics, no place. But if may infection na makita, dun sa, kumari may pancreatic necrosis yung patient dahil nag-CT scan ka 3 to 5 days, pagkarating niya, nag-CT scan ka kasi hindi siya nag-response to treatment, and nag-CT scan ka, nakita mo may pancreatic necrosis, and then nagkuha ka ng culture from it, nakita mo na may bacteria, then you'll give antibiotics. But as prophylaxis, there's no point magbigay ng antibiotics na prophylactic sa acute panc. Okay? And what IVF ang ibibigay natin? LR. And you use hematocrit and BUN. Kaya nga, nakikita nyo, nung internship ninyo, nagpapa-request yung resident or yung consultant na BUN hematocrit every 8 hours. BUN hematocrit every 12 hours. Kasi every 8 to 12 yun, okay? To assess the response of patients with acute panc. NPO, IV narcotic analgesics, and oxygen as needed, no? Okay, so that's the end of my lecture for GI. And I hope na marami kayong nakuha. Okay, see you in the next subjects.